Good evening and welcome to Doctors on Call. It's the cough and cold season, so tonight we're going to expand on that and take your questions about lung problems ranging from pneumonia and influenza to asthma, COPD, and lung cancer. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host tonight. We're ready to take your questions locally at 218-788-2844 or toll free at 1-877-307-8762. I'm pleased to welcome tonight's panelists. Dr. Wayne Elmer, a pulmonary disease specialist with St. Luke's Pulmonary Medicine Associates in Duluth. Dr. Paul Sanford, an internal medicine specialist with St. Luke's Internal Medicine Associates in Duluth. And Dr. Andrew Wilson, a pulmonary disease specialist with Essentia Health-Duluth Clinic. Our UMD medical students answering phones tonight are Katie Casper of Grand Rapids, Minnesota, Emily Lawrence from Bemidji, Minnesota, and Aaron Smith of Kensington, Maryland. And now on to tonight's program on lung problems. Well, Dr. Elmer, in the intro there, I mentioned COPD, and I know that patients hear a lot about this COPD. What is that exactly?
Well, COPD stands for chronic obstructive pulmonary disease. COPD is the fourth leading cause of death in the United States and actually worldwide. It's a chronic lung disease that's characterized by difficulty moving air in and out of the lungs. It has a very strong association with smoking. About 85% of patients with COPD are smokers or have a significant history of smoking. It tends to be associated with a more extensive smoking history. We describe a smoking history in pack years. For example, if you smoke a pack a day for 20 years, that would be a 20-pack year history. So people that smoke a half a pack or a pack a day for 5 or 10 years are probably not at risk. But people that smoke up to a pack a day or more for 20 years or longer start to enter into that danger zone for COPD. There's some confusion amongst people about the difference between COPD and asthma. Asthma is generally not the disease that's associated with smoking, although smoking can certainly aggravate asthma and make it worse. But most people who develop asthma don't develop it as a consequence of smoking. And probably the primary difference between COPD and asthma is that asthma, when adequately treated, is a largely reversible disease. And by that I mean with proper therapy, with medication and avoidance techniques, we can help people have relatively normal lung function. Whereas people with COPD, the C stands for chronic, and that means that in most cases it's largely not reversible. We can improve their lung function with medication and with therapy, but we can't make it normal again.
Okay, well, thank you. Well, Dr. Sanford, Dr. Elmer mentioned treatments for, say, asthma. How do you treat asthma?
Well, the different levels of severity of asthma. Some people with asthma just occasionally will get tight breathing and they just use a little albuterol inhaler that helps to rescue them when they're tight. Other people have severe life-threatening asthma and need to be on chronic inhaled steroids that will help to prevent bronchospasm and then still use their albuterol puffer for when they're feeling extremely tight. People need to measure their airway force or a little peak flow meter and need to stay on top of it because it does kill people.
Thank you very much. Dr. Wilson, we have a caller from Duluth who would like to know what's the difference between pneumonia and bronchitis?
Well, that's a good question. Infections can affect the airways leading to the lungs, and they can also get deeper into the lungs and affect the smaller, more further down components of the lung that are responsible for transfer of oxygen and carbon dioxide. Bronchitis is primarily an inflammation that affects the larger airways that are conducting air. Both conditions can cause significant cough and sensation of chest tightness. However, pneumonia tends to be more pronounced and more often involve fever and a more aggressive inflammation of the lungs. And typically, when someone has a fever and significant productive cough, an X-ray will show an area that's affected by inflammation that requires antibiotics, whereas often episodes of bronchitis can be more often caused by viruses and may not require antibiotics for a significant period of time.
Thank you. Dr. Elmer, we have a caller from Cloquet who would like to know about sarcoidosis. What's that all about, and how do you treat that?
Yeah, that's a question that seems to come up each time on one of these shows. But sarcoidosis is a fascinating disease. It's an uncommon disease. It's a disease of inflammation. And by that I mean it's not caused by an infection. It's a disease that can affect literally any organ system in the body. It can affect the brain, the eyes, the skin, heart, lungs, kidney, liver. However, about 80% of people who have sarcoidosis will have respiratory symptoms. So the majority of sarcoidosis patients wind up seeing pulmonologists. The fascinating thing about sarcoidosis is we don't actually know what the true incidence of the disease is, because the majority of people who have sarcoidosis don't actually have any symptoms from it. And it's something that's typically discovered incidentally, meaning it's discovered when we're looking at something else. Commonly, it's discovered when a chest X-ray is done. Oftentimes, it's done for other reasons. Sarcoidosis classically causes enlargement of the lymph nodes in the center of the chest. So that's usually distressing because there's some other serious diseases like lymphoma that can cause that.
Is there a treatment for it?
There's a very effective treatment for sarcoidosis. Thankfully, as I said earlier, most people who have sarcoidosis don't have symptoms and don't actually require treatment. But for people that do have symptoms, it's very treatable with steroids, with corticosteroids, prednisone.
Well, thank
and
you.
prednisone is almost uniformly effective.
Thank you. We have a caller from Brule, Dr. Sanford, who has fluid in her lungs, and it's not pneumonia. What other causes? What else can cause fluid in the lungs?
Well, a lot of things that can cause fluid in the lungs or around the lungs. Something called a pleural effusion is where you have fluid around the lungs, and that can come from heart failure or infection, any number of things. And when you have fluid actually in the tissue of the lungs, you think about heart failure again. If the main heart chamber isn't able to pull the blood out of the lung and send it back out to your arms and legs, the lungs will become boggy and fluid-filled.
Thank you. Dr. Wilson, we have two callers about the same condition, one from Port Wing, one from Duluth. It's pulmonary fibrosis, idiopathic pulmonary fibrosis. How serious is it? What can you tell us about it?
Well, pulmonary fibrosis is a condition in which there is scarring throughout the tissues of the lung. In most cases of pulmonary fibrosis, the cause of the condition is not known. It tends to affect people who are in their 50s, 60s, or older. And it's a condition that, up until recently, we didn't have any proven treatments for. And it tends to be something that progresses, causes limitation in lung function and difficulty breathing, and is something that can be fatal over time. Recently, there are two medications that have been approved for use in pulmonary fibrosis, which is exciting. They are medications that require a lot of discussion because they don't cure the condition. They can slow it down, but they also have significant side effects and require monitoring of liver function and can cause significant side effects. But there are potential treatments that require discussion in a clinic setting to discuss the risks and benefits for that condition.
Well, thank you. Dr. Elmer, we have a caller from Brule wants to know about what are the early symptoms of mesothelioma, or are there symptoms?
Yeah, mesothelioma is a cancer of the lining of the lung, called the pleura, actually lining of the thorax. Thankfully it's a rare cancer. It has a very strong association with exposure to airborne asbestos fibers. There's some concern that there could be an association with mesothelioma and exposure to taconite dust. There was a large study that I think was recently concluded. I think the association hasn't quite been firmed up yet. But the most common symptom of mesothelioma is shortness of breath. And unfortunately, that's a very nonspecific symptom because most disease processes of the lungs. That was one of the reasons that sort of attracted me to pulmonary medicine, because it has sort of a short review of systems. Are you short of breath? Do you cough? Do you have chest pain?
Sure.
And but mesothelioma typically causes shortness of breath. It tends to be sort of insidious or slow onset. It's readily diagnosed with chest imaging studies, chest X-rays and chest CTs. Almost always requires a surgical lung biopsy to confirm a diagnosis. It's a tough cancer to treat.
Yeah, thank you. Dr. Sanford, a caller from Evelyn, wants to know about what is aspiration pneumonia.
Oh, yes. So aspiration pneumonia is a type of pneumonia where something you didn't intend to go into your lungs, that instead you wanted to go into your stomach, goes into your lungs. Sometimes it can happen if people vomit and inhale, or if you're eating something and it goes down the wrong hatch. Sometimes during the night if you have acid reflux and it gets up into the throat and you aspirate it into the lungs. It can be a serious type of pneumonia. It often is a type of organism that doesn't necessarily need to use oxygen, or called an anaerobic infection, and they're taken very, very seriously.
There's a question from a caller in Duluth who wants to know about obesity. Can that cause shortness of breath?
Yes, obesity can cause shortness of breath. In approaching shortness of breath in the lungs, we not only look at the lungs themselves, but of course other organs that affect the lungs, and that includes the heart, but it also includes the rib cage and tissues outside of the lungs. And certainly significant obesity can cause restriction in lung function, which can cause shortness of breath with exertion. There are also some conditions with obesity that include something called hypoventilation, in which a person doesn't breathe adequately and retains carbon dioxide, which can cause sleepiness. And in addition, sleep health is an important component of lung conditions. And obesity is a risk factor for obstructive sleep apnea, which is also something that's more common in patients with COPD. And so looking at sleep health and optimal diet and exercise are important for lung and sleep health.
Thank you. Dr. Elmer, you had mentioned about prednisone as a steroid. Excuse me, a caller from South Range wants to know, well, what is a steroid?
Well, a steroid is basically it's a hormone. It's a substance that our own body produces. There's a couple different types of steroids. Most people are probably familiar with anabolic steroids, which are derivatives basically of testosterone, and those are the steroids that the baseball players take to get big muscles and hit home runs. The steroids that we typically use in treating a lot of different respiratory conditions are corticosteroids. They're not anabolic steroids. They don't make your muscles big. In fact, they can have sort of the opposite effect. They can make your muscles weak if you're on them for an extended period of time. But we use them primarily for their anti-inflammatory properties. And so corticosteroids have enormous importance in treating many different lung conditions. We have to be wise about how we use them because they confer significant benefits in terms of improving health. But for people that have to be on them on a daily basis for an extended period of time, they have a number of undesirable side effects. And so we have to be wise about using them so that we get the maximum benefit and minimize the adverse side effects of being on them for a long time.
Thank you. Dr. Sanford, a caller from Hermantown wants to know, can COPD turn into lung cancer?
Oh, people who have COPD from cigarettes certainly are, anything related to cigarettes is associated with lung cancer. I mean, if it weren't for cigarettes, we'd all be short order cooks at a restaurant here in town. The biggest association with lung cancer that I know of is tobacco, and that's the biggest associated risk for COPD.
Thank you. Dr. Wilson, here's a good question about what about screening for lung cancer? I mean, are there new ways to screen for that, or is screening helpful?
Yeah, it's a good question. And recently, there was a large study that did show a benefit to screening for lung cancer with CT scanning. And we're starting a program at the beginning of March that will offer that screening. This is something that is offered to people who are between the ages of 55 and 74, and in some cases even a little bit later. For those who have smoked at least a pack of cigarettes per day for at least 30 years, or the equivalent, say smoking 2 packs a day for 15 years, and who have smoked sometime within the last 15 years, there has been shown some benefit in screening in terms of decreasing some cancer deaths from lung cancer through early intervention. One issue that needs to be addressed in talking to patients about lung cancer screening is that the majority of abnormalities that are found on screening CT scans are not lung cancer. And so it's important that there's appropriate follow-up of any abnormal findings to determine the right approach and not do biopsies or invasive tests unnecessarily.
So sometimes it creates more questions than it answers.
It will create questions, and those questions have to be addressed appropriately.
Thank
And
you.
especially when it comes to lung cancer, prevention is way more effective than screening.
Thank you. And I think that is the really important point, that the message should be stop smoking and prevent smoking.
Good point.
That's the main message.
Thank you. Dr. Elmer, a caller wants to know, she has sports-induced asthma in high school. Will she be more susceptible to other forms of asthma as she gets older? And maybe that a corollary to that is, if kids with asthma, are they going to have it all their life?
Yeah, maybe not. There are a number of people who develop asthma in adolescence that can outgrow it. Asthma has what we call a bimodal distribution of presentation. We see asthma show up at sort of 2 stages in life. One is in adolescence, and many people will outgrow that. Some people who develop asthma in adolescence will continue to have asthma as adults, but many people, when they get into their 20s, the symptoms may resolve. There's a second period in life when people get into their 40s and 50s. They may actually develop asthma later in life, even though they never had asthma or chronic bronchitis as a young person. Exercise-induced asthma or exercise-induced bronchospasm is also something that may resolve as their airways mature, but then again it may persist through adulthood. Thankfully, we have good treatments for that tend to be effective, and so even if it does persist, it's definitely treatable.
Thank you. Dr. Sanford, a caller from Duluth would like to know about Tessalon pearls for cough. Are they good, or do they do anything?
Well, Tessalon is another type of, it's called an antitussive, something to help you stop coughing or kind of cool that tickle that makes you want to cough all the time. If Tessalon works, it's great. Other things, guaifenesin, there are all sorts of different remedies.
Some of the over-the-counter stuff, does that work?
Dextromethorphan.
Yeah, the
Yeah,
DM.
they're better than nothing. The narcotic antitussives, codeine, hydrocodone, are probably the most potent, but they also have the most side effects. So,
Yep. Tessalon's nice, it doesn't sedate.
Right. And
Yeah.
it's important to note also that these are mostly treating symptoms rather than the underlying cause. So while treating the symptom of cough, it's important to try to identify what the underlying cause is and treat that as well.
Thank you. Dr. Wilson, you brought up earlier about sleep apnea, and we have a caller from Cloquet would like to know, are there lung problems related to sleep apnea?
Well, that's a really good question. Sleep apnea is a condition in which typically, because of obstruction in the upper airway, the oxygen level falls repeatedly at night. And that causes a person to awaken even if they don't realize they've been awake. And this low oxygen can also cause strain on the right side of the heart, which can cause right-sided heart failure. But it also is known to complicate chronic obstructive pulmonary disease, COPD. There's greater overlap between those two conditions, and recently there has also been identified a connection between obstructive sleep apnea and asthma. So certainly those two are related, and treating both obstructive sleep apnea and underlying lung disease is important for overall health.
Thank you. Dr. Elmer, a caller, wants to know about COPD and asthma. Are there exercises that can be done to help the lungs?
Yeah, a common question. Really, any exercise is lung exercise. A lot of people are interested in about, well, can I do something if I take good deep breaths and, in the chair, is that good for my lungs? If you keep that up for more than a minute or so, you're going to hyperventilate and get dizzy and pass out. So really, walking is wonderful exercise for the lungs. Running, jogging, cycling, exercise, any exercise that exercises the body is good exercise for the lungs. So inactivity, being sedentary, is the worst possible things for your lungs. Your lungs are
so no matter how bad they are, keep moving. Got to keep moving.
Activity, exercise is the fountain of youth.
Great. Dr. Sanford, question here about pertussis or about whooping cough and immunizations. What should we do about that? Do we need to get a booster?
Well, if we're a developed nation, we should be preventing suffering from things like pertussis, whooping cough, measles, mumps, rubella. It's just tragic when people get these preventable illnesses when it's so easy to prevent them with a vaccination. So please vaccinate your kids.
Thank you. Dr. Wilson, we have a caller from Hayward wanting to know, what is tracheal stenosis?
Well, tracheal stenosis is a condition in which there's narrowing of the trachea, which is the airway, the upper airway leading down to the lungs. This is a condition that is fairly uncommon and usually complicates prior procedures, such as when a person has had an airway, such as a tracheostomy that's gone in through the airway, but can be caused by other things. And this is a condition that would need, if it's significant, would need to be treated with either stenting or surgical intervention, or rarely a person would require having an airway put in to bypass the area that's narrowed.
Mm-hmm. Thank you. Dr. Elmer, a caller from Hibbing would like to know about bronchoalveolar cell carcinoma.
Mm-hmm.
What is that? That's a type of lung cancer,
Yeah.
right?
It's an uncommon type of lung cancer, bronchoalveolar cell carcinoma. We break lung cancers down into two broad categories, small cell lung cancer and non-small cell lung cancer. And the reason we break them into those two categories is that they're basically treated differently. Small cell is almost always treated with chemotherapy. Non-small cell lung cancer preferentially is treated with surgery if that's an option. Bronchoalveolar cell carcinoma is a non-small cell lung cancer. Nobody wants to have a lung cancer, but if you have to have a lung cancer, that's a good one to have because it's one of the more indolent types of lung cancers. It tends to grow slowly. It has a lower metastatic potential. It's less common. I think it's only about, I want to say, 3 or 4% of all lung cancers. Mm-hmm. It's detectable with screening, but classically it's a nodule, it's an abnormality in the lung that just is there and slowly progresses, usually over a period of years, and requires a biopsy to diagnose it. And it's curable with surgery if caught in time, and usually it is caught in time because it grows so slowly.
Well, thank you. Well, we just have a couple of minutes left. Dr. Sanford, another immunization question from Grand Rapids. The pneumonia shot, is that a once-in-a-lifetime thing?
Well, it used to be. A pneumococcal vaccine was once in a lifetime, but you'll hear about the Prevnar vaccine now that generally should be also given. There's a spectrum that each vaccination covers. So if you've already had your pneumococcal vaccine, I'd recommend you get the Prevnar, and then a year later, the second Prevnar. And as far as the date for people who haven't had a pneumococcus vaccine, is it after age 50 for
Generally 65.
65 now. Okay.
Well, for getting both,
Yep.
usually 6 to 12 months apart.
Yep.
Thank you. And we just have a minute left. Just a quick thing here. Is a relationship between rheumatoid arthritis and damage to the lungs? Can rheumatoid arthritis cause lung things too?
Yeah, that's a really good question. And rheumatoid arthritis can cause a number of different lung conditions, from nodules to scarring, or even effects on the upper airway. And if a person does have rheumatoid arthritis and there's concern about an underlying lung condition, then typically imaging and referral to a lung clinic is important to discuss those possibilities.
Well, thank you very much. Well, we're out of time. I'd like to thank our panelists tonight, Dr. Wayne Elmer, Dr. Paul Sanford, and Dr. Andrew Wilson, and our medical students, Katie Casper, Emily Lawrence, and Aaron Smith. Please join Dr. Ruth Westra next week for a program on cancer, when her panelists will be Dr. Jeff Koopman, Dr. Brett Friday, and Dr. Basab Gwili. Thank you for watching, and good night.